Hello. Shweta ma'am.
Yes, he has various national and international publication and book chapters in the field of stuttering. He has 3 book manuals in his credits. He has presented scientific research at various national and international conferences and won awards. His research focuses on the mechanism of underlying stuttering, treatment of stuttering, and emotional issues in stuttering. He received his post-graduation and doctoral degree in speech language pathology from All India Institute of Speech and Hearing, University of Mysore. We heartfully thank you, sir, for joining with us and presenting this fantastic topic. We are all eager to hear from you, sir.
Thank you, sir, for that generous introduction. And yeah, before we move on to the today's session, this is, I hope most of you will be knowing him. He's one of the American psychologists who did a pioneering study in the field of speech and hearing, especially in stuttering, Dr. Wendell Johnson. His one of the famous quote is, "Always and never are the 2 words you should always remember never to use it." When it comes to stuttering, especially, there will be a lot of variation among the stuttering features, and it is a heterogeneous in nature. And there is an individual variability within the subject, also among the stuttering population. So whenever you are counseling or whenever you are giving a research statement, make sure that always and never are the 2 words you should always remember never to use it because of its inconsistency. So with this background, before starting the today's lecture, let me have a quiz so that Bhaskar sir will take over from now.
So there is a link there, and this is a Google form. Please click on the link. It will be provided in the chat box as well. You have got 90 seconds to fill it up. So whoever has participated till now, please do fill it up. We can Disha ma'am, can we wait for a few minutes for more participants to join in?
Sir, let's start filling the form.
Let's start then. Okay, please, participants who have joined in, please fill up the Google form and submit it within 90 minutes. We'll stop it after 90 seconds. Sorry, 90 seconds, not 90 minutes. Yeah. Is the link visible for everyone? Rakesh sir, can you?
Yes, sir. It's visible to everybody. It's there on the chat box.
Okay, okay.
Yes, I'm getting responses. I kindly request every participant to please participate in the quiz competition. There are only 5 questions.
and very less time.
Yeah, already it's 10 minutes. So I request everyone to kindly fill in as soon as possible.
So Rakesh sir, should we stop
Yes.
the responses from coming
Yes, sir.
in?
I got around 17 responses, 17, 18. So I guess that is sufficient for the discussion.
Okay, okay. So it's like participants, we request you to please not to fill up the form like because the time is over, and that will be enough for us to discuss. Thank you.
Yeah. So our first question was analogies are treatment techniques. So I guess 63% of the participants has answered false and 36% of the participants have answered true. So as you know, the majority wins. The correct answer is analogies are treatment techniques. So it is actually it's the reverse case here. So analogies are not a treatment technique. For your information, that is analogies will facilitate for a treatment technique. It will facilitate fluency. It will try make the student understand or the child understand. But analogies are not standalone treatment technique. So the answer is false. So most of the 63% of them have answered correct. So second question is dysfluency is the only issue in school age children who stutter. Again, majority wins. It's false because in school age children who stutter, dysfluency is not the only issue. They have other kind of emotional issues, negative attitude, embarrassment, shame, and poor scholastic performance, and so on. So again, most of them have answered correctly. I'm happy. And list the treatment techniques or procedure to treat school age children who stutter. So I have got various answers. And the first one being the analogies. I told you it is just a part of treatment. It is not a standalone treatment technique. Camperdown program, it is treatment technique for adults, not for children. And metronome, modified airflow, pause and talk, prolonged speech or hybrid, relaxation, bounce, token economy, decrease rate of speech. So we have got various types of answer. Let's see it in our presentation in detail. So which treatment techniques procedure do you use to treat school age children who stutter? Hybrid PS and PT, light contact, slow rate of speech, Litcomb, first word prolongation technique, metronome, midvas, response cost, stuttering modification. It's good. There is a lot of treatment techniques names have been mentioned here. Some of them are outdated and some of them doesn't have any evidence base to support this. Let's see in detail in the presentation. And my last question was, are you confident to treat stuttering? And only 25% of them have said 100% they're confident, but rest I think 45% are they have rated 4, and we need to work on these three subgroups where they have said that they are not confident enough to treat stuttering individuals. Okay, fine. Let's go back to our presentation. So you guys have mentioned some of the treatment technique names in the quiz competition, and these are some of the treatment techniques that today we are going to discuss in detail. And you may ask me, how did you select these treatment techniques, sir, out of so many? So I selected this treatment technique based on the evidence. That is their efficacy have been checked or not? If there is a research support to say that these treatment techniques are effective, then we have included those in our present discussion. Moving on to the school age population. Whenever we say school age population, we have to look at the age range. 6 years to 12 years is the age range that we call them as school age population. And some of the authors say it can go up to 14 years. And intense regular therapy is challenging in school age population. The reason why I make this statement is most of the parents focus on scholastic performance here. Whenever we ask for weekly 3 sessions or 4 sessions, they will be bargaining with the therapist, saying that, sir, can't you treat him with weekly once or twice? He will miss schools, he has exams. Most of the parents' focus will be on scholastic performance, but they don't give much of the interest towards the fluency. So intense regular therapy is challenging. But however, if you have to see the good prognosis, I would suggest intense therapy, that is 3 to 4 sessions per week, and each session accounting for 1 hour, that is 60 minutes in duration. And apart from disfluencies, one of the question asked in quiz, apart from disfluencies, school age children who stutter are more prone to bullying, teasing, social withdrawal or avoidance, negative speech associated attitude, or elevated anxiety issues. And lastly, children are observed to have good prognosis compared to adults. This goes for everywhere, even for hearing, language disorder, or anything. Early identification and treatment is a must. And a good prognosis can be promised when we identified as early as possible and we start the treatment. And if you look into the management of stuttering in school age population, there are 3 approaches mainly. The first one being the direct approach, indirect approach, and mixed approach. I'm not going in detail regarding the approaches, hence it has been dealt in the previous talk by Dr. Divya. And as we are in a school age population, it will be mostly direct approach. Most of the treatment techniques that we use in school age population follows direct approach. What is this direct approach? In this approach, the treatment technique specifically targets the stuttering related speech behavior, using stuttering to deal with using strategies to deal with stuttering. That could include speech modification. One of the speech modifications are reduced rate of speech or prolonged syllables, or stuttering modification strategies. That could be modifying a stuttered word using cancellation, pull out in order to reduce the disfluencies or secondary behaviors. So therapy techniques which directly alter the speech mechanism or the way we speak, that is known as direct approach. And these are the list of therapy techniques that uses the rationale of direct approaches. Those are Litcom program or response course. Some of them have named them, which are highlighted in bold. So in this list, you might ask me, sir, which one to use among these? So I would say go for the ones which have evidence. That means where the researcher have checked for the efficacy of the study, efficacy of the treatment program. Please use those treatment technique so that it can be used confidently in our clinical population, because they have already efficacy has been established for this treatment techniques. And stages of stuttering therapy. So in any stuttering therapy, there are 3 stages. The first one being the inducing fluency, second one being the generalization of fluency, and third one is maintenance of fluency. But unfortunately, what will happen, it is relatively easier to induce fluency using any of these techniques. It can be done within 10 sessions maximum, 4 to 5, and an average maximum within 10 sessions. However, the severities, we can induce fluency and reduce disfluency. But most of the time, what will happen, the parents or the stuttering individual, they will quit therapy because they would have seen an improvement within 10 sessions and they stop and they don't go for the second stage and the third stage. This will lead to higher relapse. What is relapse? Reoccurrence of stuttering even after professional treatment is known as relapse. So even after giving therapy, stuttering will come back because they wouldn't have moved from first stage to second, seconds to third. So after inducing fluency, clinicians, please make sure that generalization of that induced fluency and maintenance of that induced fluency is very much important. If not, stuttering will come back. And I was speaking about analogies. So what are analogies? And it's been dealt in the last series, but still analogies are in the way that we use it in our day-to-day life, or we use it in our class to make the students understand. So analogies helps the students or the children to understand the concept more easily. One of the example here is, it is very difficult to find my key in my room. because it is like as difficult as finding a needle in a haystack. So I'm comparing how difficult to find my bike is in my room to a finding a needle in a haystack. So giving those analogies, we can make the children understand what we are going to trying to explain the concept. The commonly used analogies are these. One of them are lily pad analogy or a finger thumb analogy. And it's not like we don't have to stick to the analogies which have been given already. We can use our custom made analogies. These analogies help the children or help the clinician to make the child understand regarding the types of disfluencies. Example, if it is in lily pad, the frog, if the frog is keep on jumping on the same pad, the same lily pad, then that means we can say that this is repetition. For an adult, you can teach and demonstrate what is repetition, but for kids it is difficult for them to understand and make them comprehend what we are saying. So given with the lily pad analogy, we can make him understand repetition, block, or prolongations. Similar to that, making them understand what a disfluence is, and custom made analogies can be used to teach them when to use the treatment technique, like example prolonged speech, when to use that, or pause and talk, whatever it is. So custom made analogies can also be used for treating children who stutters. So our first topic of discussion here is response cost. Again, response cost was in detail dealt by previous speaker, that is Dr. Divya. And response cost is predominantly used in preschool children who stutter. And the clinical impression of response cost in school age children is very promising. However, there is no evidence-based research to support this statement. So clinician, you are welcome to check for efficacy of response cost in school age population. And this can be tried in younger school age children, that is 6 to 9. However, it is very much challenging for older children, that is who are at the higher range, that is around 12 years or 13 years, because they may not be very much inclined towards your tangible reinforcement or the token system, because the younger children will be very much happy and they will understand the procedure and they will like it. But in older children, it is difficult for them to like or get interest in our token system. So response cost, it can be used in school age population. However, with younger one, and research, evidence-based research is yet to find that is it effective or not in school age population. And the next one is LITCOM program. Again, in detail, LITCOM program was explained by Dr. Divya. And this is also like response cost, predominantly used in preschool age population. And it comes from Sydney, that is Australia. It is named after a suburban city in Sydney. And this is from our smiling researchers, Professor Mark Onslow and Anne Packman. And it is from ASRC, that is Australian Stuttering Research Center. And LITCOM program was tried on a school age population who stutters. And in school age population, like it was done in a phase 1 clinical study. And the post-treatment results revealed a decrease in stuttering significantly. But however, in school age population, time management is very much challenging for parents, because LITCOM program is a parent-delivered treatment system. Here, they will visit the clinic once in a week, and the clinician will teach the parent, and they will deliver the treatment. That is, they will place the response contingencies for fluent speech as well as disfluent speech. As you know that most of the children will spend 6 to 7 years, 7 hours in school. But in order to carry out this treatment program, it is very much difficult for parent in school age population. Kaushik et al. Conducted a phase 1 clinical trial using LITCOM program for school age population, that is 6 to 10-year-olds children who stutter, and the results are displayed here. The graphical representation shows you that there was a statistically significant difference, that is reduction of percentage of syllable stuttered from pre-treatment to post-treatment for almost all the kids. That is, for like almost 10 kids showed a promising improvement in fluency out of 12 kids. And again, phase 2 clinical trial as well as phase 3 clinical trial is yet to be done. Only phase 1 has been done till now. And the next one is Westmead program. Again, a suburban city from Sydney, and from our smiling researchers from ASRC, that is Mark Onslow as well as Professor Mark Onslow and Professor Anne Packman. Westmead program is also known as syllable timed speech. The short form is STS. Syllable timed speech. As the name only suggests that, as the name gives us the what is the rationale here, there will be a minimum differentiation in linguistic stress across the syllable. That means saying each syllable at a time to a rhythmic beat. Uttering one syllable at a time for one rhythmic beat. That is syllable time speech. Here we are trying to take away the linguistic stress that has been put up on the speaking task that might trigger the stuttering for individuals who have vulnerable speech motor system. This is basically based on a syllable initiation model given by Pacman et al. In 2007. Here we say that each word or each syllable have different linguistic stresses. So if you make everything with an equal stress to the rhythmic beat, then we are reducing this stress level so that there will be no stuttering that will be triggered due to vulnerable speech motor system. And the STS program, and this is also like LITCOM program, it's a parent delivered treatment program. Here once in a week the parent and the child will visit the clinician, and the SLP will demonstrate and imitate at a near normal rate with a normal intonation. Here I will demonstrate the STS for the child in front of the mother or the father, and the child will imitate my STS speech with near normal rate and intonation. And frequency I already told you, once in a week, and the speech sample will be recorded, and maintenance of STS for a period of 1 year is done. That is follow up. That, as I told you, after any fluency inducing, we have to generalize it, and as well as we have to maintain the fluency up to 1 year, so that we have to follow up it up to 1 year. So there is a small video for STS, how to demonstrate STS, and the courtesy is from again ASRC, Australian Stuttering Research Center from Australia. I will play the video. Please listen carefully. Here the clinician will demonstrate the STS and the child will start imitating it using syllable time speech.
I'm going to teach you a cool way of talking called syllable talking. It sounds like this. Kicking, swinging, climbing. Can you copy me? Kicking, swinging, climbing. Great syllable talking. Let's keep going. Copy me. Kicking a ball. Swinging on the swing. Climbing up a ladder. Perfect.
So here the clinician will say, utter each syllable with equal stress according to the rhythmic beat, like kicking, climbing, like this, so that it will reduce the linguistic stress. And again, Andrew et al. In 2012 check for the efficacy of syllable time speech in school-age children population, a phase 1 trial. In this, there was a drastic reduction in disfluency from pre-therapy to post-therapy. However, not all the patients had a statistically significant reduction in percentage of syllable stuttered for phase 1 trial. For that, they thought of including verbal contingencies, so that they called it as hybrid treatment, that is the Oakville program. In this, what they did is, it is very much similar to STS phase 1 trial, but with that, the portion of a LITCOM program, that is placing the response, that is verbal contingencies on fluent speech, they have included this from LITCOM program as well as syllable time speech from STS phase 1, and they combined both LITCOM program's verbal contingency and STS phase 1 trial, so they made it as a STS phase 2 trial or Oakville program. Here it is very similar. The child will come to the clinician for once in a week, and the clinician will teach the child how to talk its syllable time speech, and he will also demonstrate it, and the parent will be asked to place the verbal contingencies for fluent utterances, like that was a very good speech, that is very good, and you were really fluent, like that positive verbal reinforcement will be provided. And this is again Andrew et al. In 2016. They checked for the efficacy of phase 2 trial. That is phase 2 trial development of syllable time speech treatment for school age children who stutter. And in this phase 2 clinical trial, the percentage of syllable stutter decreased drastically from pre-therapy to post-therapy, and it was maintained up to 12 months follow-up. That means all of them had improved fluency, and the induced fluency was maintained up to 1 year. That is a very good and promising results that have been found out from STS phase 2 trial. And the last, second hybrid treatment program is Delphin speech treatment. And I don't know how many clinicians or SLPs will be aware of Delphin speech treatment. The reason for this is most of the Delphin speech treatment program literature is available in German, because this treatment is originated in Germany for children and adolescents. The reason here is most of us are not aware of this treatment here is because the publications are all in German language. Here there are two things. One is deblocking the impulse, and second one is nasal swinging accent. So let's see what is deblocking impulse. Before that, we need to teach the patient or the child costo-abdominal breathing. That it's just the word is big, costo-abdominal breathing. The actual meaning is trying to breathe with both muscles, that is coastal muscles as well as abdominal muscles. This type of breathing is seen in horses. So they intake a large number of oxygen and their lung capacity is really good. So costo-abdominal breathing, we will try to teach that. Use both the muscles for breathing, and by end of the first syllable have a deblocking impulse. That is, it's a kind of sigh. This sigh will make that larynx as well as false vocal folds and true vocal folds are very much in relaxed state. So deblocking impulse should be used in every syllable with the main accent. Example, if I say it in Kannada, Nanna hesaru Rakesh. Na, 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 ra, ke, sh. After every syllable, you have to sigh, like a yawn sigh technique in voice disorder. After every syllable, you have to sigh. That is the first step to reduce the tension. And the second step is after 5 days, the second step is introduced, that is nasal swinging accent. This is something which is like introducing the nasal tinge for all the vowels. We have to start with example like Nanna, Rakesh, like that. So before initiating a vowel, you are having it as with a nasal characteristics to that voice onset. So what will happen? These nasal characteristics will facilitate a soft voice onset. And one more thing which is very surprising here is Delphin incorporates European drum sessions in order to foster a sense of community and to improve concentration and coordination skills. One of the reason they work on here is they don't have coordination between respiration and phonation system and as well as articulation system. Because of this incoordination, they might be stuttering. So in order to increase this coordination and in order to increase the focus of the child, they will join the children to European drum session. So whenever you are learning to play drums, you need a high level of concentration and eye-hand coordination. So in order, if you train that, then the child will be very much good with coordination skills, and socialization skills will also be developed. This is Delphin speech treatment. And again, Killman in 2018, a phase 2 clinical trial was done on 56 children. The mean age range was 13 years. And the results showed that there was a pre-treatment percentage of syllable stutter was 12%, and post-treatment it was 4%. Improvement was seen in speech naturalness also. That means this Delphin treatment technique was very much effective in reducing percentage of syllable stutter in school-age children who stutter. And the next one is gradual increase in length and complexity of utterances. That is GILCU. Some of our students will call it as JILCU, but gradual increase in length and complexity of utterance is the expansion form. It was first founded by Richard and Mundy as well as Ryan in 1971. And this is a little bit complex procedure. Here we have got 54 steps in 3 series. And this is really complex and it is very tedious process because one therapy session consisting of 120 minutes, that is 2 hours. Here the rationale here is the child will start with one word utterance without stuttering. Here the child will be asked to speak only one word at a time without stuttering. And if he practices that without stuttering, then 2-word utterances, 3-word utterances, 4-word, like from word to monologue, finally to conversation. That is, as the name suggests, gradual increase in length and complexity of utterances. As the child speaks for 5 minutes without any stuttering, then we will be placing response contingencies. That is, we'll be placing verbal reinforcements, saying that you did good, that was better, like that. But verbal contingency, surprisingly, here at the GILCU says that it includes stop and speak fluently. And usually we don't say the child to stop or speak fluently. We indirectly say, don't you think your speech was little bumpy? Or was your speech correct? Like that. We say indirectly, we make the child aware of the problem. We don't say directly. But however, here, surprisingly, verbal contingencies include stop and speak fluently. One of the reason could be it was developed in 1980s and 1990s, and most of the clinicians doesn't use GILCU, but there is a evidence that has been generated for these two. In 1983, Ryan and Ryan established efficacy for GILCU in children and adolescents, that is 7 to 18 years. Post therapy speech sample analysis indicated that disfluency is reduced significantly. And again, after some 10 years, they did efficacy study for same program, that is program stuttering treatment for children, Ryan and Ryan. And this time they included 24 children with 11 years as mean age range. And out of 24, 23 showed improvement in fluency. Also, generalization and maintenance of fluency were reported. So till now, we saw Westmead program or Litcombe program or GILCU or Delphin method, all STS program. All these have been used in Western population, that is Western countries. But when it comes to Indian scenario, which treatment technique do we go for in most of our clinics? As we saw in quiz competition, we saw prolonged speech, we saw pause and talk, we saw so many other treatment techniques. So the one widely used in the Indian clinical situation is prolonged speech. Here, the prolonged speech is a combination of slowing the speech by prolonging the vowel concept, not the consonant here. Here, in the prolonged speech, the key is prolonging the vowels, not the consonant, with soft articulatory contacts and smooth transition from one sound to another with exaggerated continuity to facilitate fluency. This is most popular, let it be in the Indian scenario or in Western context. In Western context, they call it as Camperdown program. In Indian context, we call it as prolonged speech. Again, it has got 3 stages: establishment, that is inducing fluency, generalization, and maintenance. And many techniques have been developed based on prolonged speech. And if you are going for prolonged speech with school age population, and there is a treatment protocol that has been given by Dr. M.N. Hegde in 2006. Please refer treatment protocol for school age children who stutter. In that, he has explained everything in step by step, that is prolonged speech. In this, first we need to establish the fluency. In order to establish fluency in prolonged speech, there are only 2 tasks for the child to master. The first one is slower speech rate with syllable prolongation, and the second one is normal prosodic feature. One of the drawbacks of prolonged speech is what people will say, that you are damaging the natural speech of the child. Example, if I want to demonstrate prolonged speech, it will be like prolonging the vowels of each initial syllable. That is na, na, he, saru, Rakesh. I am not prolonging the middle syllable or the final syllable, only the initial syllable. So if he is having very severe stuttering, then we will ask him to prolong all the syllables in the word and the sentence. If he is having like severe, not very severe, then we may ask him to prolong the first vowel of each word. I will repeat it. Na, na, he, saru, Rakesh. Like that. We will ask him to prolong it. That is inducing of fluency. However, if you stop at this point only, then obviously his natural sounding speech will be damaged. Hence, we need to desensitize the usage of prolonged speech once stuttering has been evaded. Once the stuttering has been reduced, then you have to reduce the prolonged speech usage also. How do we do that? Then here we would have asked to prolong each syllable in each word, then in the beginning of the each word, then only in the beginning of the each sentences. Then finally, before discharge, we will say that you have to prolong whenever you anticipate stuttering or whenever you think that you are going to stutter. That point of time, in order to get out of stuttering, use prolongation and get out. At that time, what will happen? There will be normal prosodic features. So these are the two stages in prolonged speech. That same thing that I have just explained. And here also, as given by M. Negre, there are three stages: establishment of stutter-free conversational speech, then narrative speech, then natural sounding fluency. So initially we start with conversation, that is clinician to client or clinician to child conversation, followed by monologues, that is narrative, story narration or anything, just a narrative speech. Last one is stabilizing natural sounding speech fluency. That is, the frequency of usage of prolonged speech should be reduced as much as possible in order to give a stutter-free as well as normal sounding speech for children. And it moves from more structured to a less structured and further to a more naturalistic settings. That is, initially it will be very structured, very formal way. We have to follow the steps. As the child gains fluency, we will move for less structured as well as from clinical settings to natural settings. That is when the generalization takes place. Whenever whatever treatment technique you teach within the four walls, whenever a child sees the clinician, he will remember that I need to use the treatment technique, and he will use the treatment technique and he will get away with the fluent speech. However, when he goes to a more natural situation like a canteen or a shopkeeper, when he is speaking to a shopkeeper or speaking to a teacher or a neighbor, that is more naturalistic situation. There the generalization should take place, not only between four walls. And criteria to move from one level to next level is 97% fluency. From establishment of conversation speech to narrative to natural sounding speech, in order to move from one to the next, 97% fluency is a must. So this is prolonged speech in school-age children who stutter. Now moving on to pause and talk. Most of clinicians would have heard what is pause and talk. It is not a new technique. Previously, it was called as a timeout technique, but now it has been renamed as pause and talk. It is given in detail in MNEGRE treatment protocols. So it includes placing the social reinforcement for talking fluently and sudden removal of that social reinforcement for stuttering. Here, the social reinforcement is eye contact, that is clinician's eye contact, the social smile, and your attention. That if somebody is listening to me, means that is the positive reinforcement. How many people will have this, what do you say? Or what can you say? If most of us will be speaking and there will be no listeners only. If somebody is giving attention to us, if somebody is making an eye contact, that serves as a positive reinforcement. And that should be there only for fluent speech. And the moment the child stutters, we are taking out that positive reinforcement and placing a contingency. That is, the moment the child stutters, we will ask him to stop. Then we will look away, we will take away the eye contact, we look up somewhere, or we will look into our watches and we will wait for exactly 5 seconds, not 4 or not 6, exactly 5 seconds. Then we again will start. You were telling something. Okay, you were telling the elephant story. Please continue with a smiling face. The moment he speaks fluently, listen to him carefully, make eye contact, smile, and the moment you anticipate stuttering, ask him to stop. The moment the clinician says stop, the child has to stop. The SLP should make sure that the child has stopped speaking. And remove your eye contact for 5 seconds. And again, this will be done in 2 steps. That is to reinforce fluency and to withdraw reinforcement for stuttering. There are only 2 tasks to master. This is, and if you ask me in comparison, sir, how much is different from prolonged speech? For prolonged speech, it is difficult for the patient to learn the technique and to use the technique in day-to-day life. But it is easier for the clinician to administer and demonstrate. But in pause and talk, it is easier for the child or the patient to undergo the procedure, but it is very tedious for the clinician in the initial phases, because the clinician should be attentive for all 60 seconds. He should anticipate the moments of stuttering. The minute or the second as a child exhibits any stuttering features or lip pressing or any tension in the muscle, he is about to stutter, we need to ask him to stop. So whole 60 minutes, we should be more attentive to the stuttering moments. Then we need to stop. And the moment you say stop, that you should make sure that the child stops speaking. This is the reason pause and talk cannot be used for preschool age population. As you know that preschool age population, that is LKG or pre-KG, and you will ask him to stop speaking, and blissfully they will be keep on speaking. They will not stop because they are kids, they are very toddlers, they don't listen to adults, and they will be keep on speaking. So this technique will not work for preschool age population, and again this will not work for reading task, because when the moment you make the child read or the patient read, then he will look down and start reading, and there will be no eye contact at all. So it cannot be done for reading task, and also it cannot be done for preschool population. And again, this will have two levels, that is conversational speech level and narrative speech level. We will start the treatment technique by conversating with the child, asking what did you have for dinner, or what did you have for lunch, what is your favorite animal, like this. After once conversation level is being successfully established, 97% fluency, then we will move to story narration, that is monologue. Again, structured to less structured and further to more naturalistic settings, in order to make sure that generalization has taken place. And best possible candidates, older children and adults, and it may not be effective for younger children, perhaps below 6 years of age, because they don't stop when you ask them to stop. And nature of reinforcement for fluent talking, you might ask me, sir, what is the positive verbal social reinforcement? That could be clinician attentive listening, smile, approving facial expression, verbal expression of approval, and continued opportunity for self-expression for the child. For him to speak without stuttering or without interruption is the reinforcement. You only think that you are very much excited, you wanted to speak to me, you wanted to tell me something, and you are like, sir, today what happened in class? I will say stop, and again I will take for 5 seconds, and again I will ask you to speak, again I will ask you to stop. How much irritating, frustrating it is that the person is keep on asking me to stop. So that serves as a negative reinforcement, and the child will start speaking fluently. Being able to talk continuously may be the ultimate reinforcers in this procedure. And timeout, here again, timeout should not be less than 5 seconds or greater than 5 seconds. And do not misuse the procedure. Most of the time what will happen, to use pause and talk, experience is required from the clinician side. The clinician should be well versed theoretically as well as practically, because if you impose timeout for fluent production, then it's going to be an issue. Whenever the child is speaking fluently, you should not say stop, or you should not discourage, or you should not remove the social reinforcement. And you should be very much quick and agile to recognize the disfluency, because if you do not ask him to stop, the children will get away with the stuttering moment. So you should be very keen observer and very much sharp at making him to give the timeout impose. And here it's only pause and talk. There is no gentle voice onset or speak slowly or use airflow management, nothing. It is only pause and talk, timeout. Other than that, we are not using any of the other therapy techniques. There it's only prolonged speech, and here it's only pause and talk. And efficacy support for this study, and myself and my guide, Dr. Santosh Maruti, we have done a thesis and we have submitted a paper, and it is under review. And here in this, for prolonged speech and pause and talk, as you can see here, percentage of syllable stutter reduced drastically from pre-therapy to post-therapy, and it was maintained up to 3 months follow-up. Similarly, stuttering severity rating also reduced from pre-therapy to post-therapy, and it was maintained up to 3 months follow-up for both the therapy techniques. And even naturalness rating here, even though we have used prolonged speech, the naturalness rating score was near normal at the level of at the time of discharge, and the same ratings was maintained up to 3 months follow-up. And this is a small table for you guys, like treatment techniques based on the severity. So based on my experience, I have made this table. So what is the, like, a patient or a child will walk into your clinic, and you will do the detailed assessment as given by, like, as taught by Dr. Santosh Maruti in the first series. So that SSI will say very mild or moderate, severe, or very severe. Based on the severity, you can choose these therapy techniques. If the child is exhibiting very mild, then I suggest to please go with GILCU or pause and talk for mild as well as very mild. And if the child is having moderate stuttering, then please go with pause and talk, GILCU. With that, you can use prolonged speech also. If the child is having severe stuttering, then pause and talk or prolonged speech, any one will work. But if the child is having very severe stuttering, like hard articulatory attacks, that is very 5 seconds block or 4 second block, or repetition with iterations of 4 or 7 or 10, then prolonged speech will be best. Because in order to get him out of that block, it is very much difficult using pause and talk or GILCU. You should go for prolonged speech. So I suggest for very severe, go for prolonged speech. For mild and very mild, go for pause and talk. For moderate and severe, any of the therapeutic technique can be used. And one more thing, if you have not been successfully reducing stuttering behaviors over a period of like 20 sessions or 22 sessions, then you might use hybrid. First, you will go for prolonged speech, and if it's not been working at all, even after 30 sessions, then go for hybrid. That is, mix both prolonged speech and pause and talk. Ask him to start speaking using prolongation of the initial vowel. With that, place the response contingencies also. So with both of these, we can go with hybrid technique. But I don't think till now either one of them will work for sure, depending upon the severity of the problem. If done effectively, if the procedure is followed correct, it should work. And last but not the last point, that is, for treating stuttering, a good and detailed counseling is very much important. Because most of the time what will happen, we ignore the part for counseling. And here counseling sessions are very much important in order to treat stuttering because of so many reasons. Those are, one among these is catharsis. So catharsis is something known as like emotional release that will happen during counseling, because in counseling, what do? We develop an interpersonal relationship between the clinician as well as the patient. So whatever the problem that he's facing, other than disfluencies like any negative speech associated attitude or elevated anxiety, all this, or the bullying, teasing, whatever it is that he couldn't even tell it in front of the teacher or the parent, that give him a chance, allow him to speak and open up. That is known as catharsis, emotional release. And negative emotions, attitude or associated anxiety, this can be assessed through communication attitude test that has been given by Jean J. Bruton and Martin Wackerhangem, or speech situation checklist, emotional reaction. With that, we'll get to know that as the child has already developed negative attitude or elevated anxiety. And if you get to know that at what all situation or what all concept that these people have developed this negative attitude and emotion, we can work on them during our therapy session. We can include them during our lesson plan only, and we can work on those and guide them. And in this, we'll get to know that is the child is suffering from anxiety, shame, guilt, grief, denial, or depression or anger. Anything that, whatever the stage that parent are there, the stages of grief, that also we'll get to know during counseling. And one should be very much observant, like how much information to be given during counseling and when to give this information. Because most of the time what will happen, even though they are in school age population, not everyone will have secondary behaviors, or not everyone will have negative speech associated attitude or anxiety. This is a myth saying that if he's having stuttering, he will have negative attitude or he will have elevated anxiety. It could be there, or it like he can just have disfluencies. Not everyone will have negative attitude. One example I have to give you is like being dark, being dark complexion. Some might be thinking that I am dark, I am not looking handsome, I am very much dark, I don't like the way I am. Girls will not like me, I hate being dark skin colored. That is negative attitude. But same another person with a dark skin may say that why I look beautiful, I look handsome, dark is what you say, guarantee color, and look at Lord Krishna, look at Lord Shiva, all are dark, and even heroes like Dunya Vijay in Kannada industry, or our Rajinikanth is dark, so I am like Rajinikanth. That is a positive attitude. That does, or they may not have positive or negative, a neutral attitude. I am dark, so what, I don't care. So all these attitudes will be there. Don't generalize because he has stuttering, he will have negative attitude. It could be negative or somewhat neutral attitude. Okay. And about facilities or cost involved in treatment options and team involvement. And also during counseling only, please inform about the cost involved and what are the therapy costs that are going to incur by the parents and treatment options that are available. And don't force them that saying that you have to come like even they are bargaining with only once or twice, don't accept or don't say yes for once in a week session, because this will not benefit both of the clinician as well as the parents. And after a month, they will say there will be no improvement. Even you can show improvement with once in a week visit. So please counsel properly for 3 sessions minimum in a week. And the purpose of counseling is to share information, to offer advice, to assist caregivers with understanding and coping up with the problem. And I have already spoken about catharsis, to provide opportunity to ventilate feelings. And in order to just summarize, we have just see the management of stuttering in children who stutter. In Western context, we use Lidcombe program, Westmead program, as well as GILCU and Delphin treatment. And this Westmead program and Lidcombe program, before it was taught to be like a clinician should be having a trained certification. That is, we have to undergo training, and a certified speech language pathologist can only deliver Lidcombe program and Westmead program. But recently, they are just suggesting that it is not mandatory. And this Lidcombe program as well as Westmead program treatment manual is available for free. It is there in the internet, that is in ASRC website. It is there for free, and you can download and you can go through the procedure and you can start implementing it in your clinics, Lidcombe program and Westmead program. The only problem here is it is parent delivered treatment program. In Indian scenario, due to various reasons, not all parents will agree for parent delivered treatment program, because of the financial or educational background, or some of our parents say that we are paying you and you have to deliver the treatment program, why should we deliver? So all these kind will be, and some of them will not understand, and most of them will not have time, because they are working force. In order to fetch bread and butter, in order to have the good quality of life, they have to work. They cannot sit with the child and delivering the treatment program. Due to that, in India, we choose clinician delivered treatment program rather than parent delivered treatment program. In case if the parents agree that we are ready to deliver treatment program for Lidcombe program or Westmead program for their children, please go for that, and please use evidence based treatment program. This modified airflow technique or bounce technique or glide technique, all these are outdated. They are not being used anymore, and they don't fetch much of the good prognosis also. So please get updated and use techniques which have evidence for the same. And if you are using any of this treatment technique, please record. Please have a spontaneous speech sample as well as conversational speech sample with different situation, and have a baseline before treatment and during treatment as well as post treatment. Collect the evidence for the same, which will help us. So the last sentence is, future is bright for us. And these are the references. If you have any doubts or any further queries, you can go through these references and you will find in detailed informations. And I would like to thank Isha SIG PP organizers for giving this opportunity for me to give a talk on the management of stuttering in school age children who stutter. And I like to thank Dr. Santosh Maruti, my guide, mentor, and supervisor, and who has been here from the day one to till date, who has been keep on supporting me and motivating me. And Department of Speech and Hearing, MCHP Manipal, and my HOD, Dr. Usha Devdas, and all the participants. Thank you, one and all. Any questions?
Thank you, Dr. Rakesh, for giving us such a great insight about stuttering in school-going children, especially on the evidence-based practices, what we need to do. Now I would like Disha ma'am to take over for the question answer sessions. Thank you.
Good afternoon, everyone. Sir, there are a lot of questions pouring in. Shall I ask right now?
Yes, ma'am.
Okay. So one of the questions asked by Sonali ma'am was, supposing I'm a school-age child, please demonstrate cancellation technique.
Again, I told you, like these stuttering modification techniques, that is stuttering modification is one is cancellation or pull out, and it has not got much of the evidence, and it's quite outdated one. And I suggest to use prolonged speech or pause and talk technique, man. Cancellation is nothing but, as you are like struggling with the stuttering, you ask the child to stop and get out of that stuttering moment and again to restart. Example, the word kage. Here I'm saying kage. Like the more you struggle in order to get the word finished. The more you struggle with stuttering, the more worse it becomes. So you have to leave it there. You have to stop it, and again you have to start freshly. That is cancellation, and it has been outdated. So I suggest to use other treatment techniques.
Also, sir, can you please mention the names of the test for attitudes assessment in children?
Ma'am, there is one for attitude you are asking, right? That is communication attitude test. It has got, it has been covered for all the age range. If you are using it with preschool age, that is known as kitty cat. If you are using it for school age population, it is known as communication attitude test. That is CAT. If you are using it for adults, then it is known as big cat. So kitty cat, cat, and big cat for assessing communication attitude test.
So this is from my side. I wanted to ask, how can we apply STS in our private practice? As in, how can we generalize? Like, if we have introduced the concept, how can we generalize the next step with this in STS technique?
Ma'am, with respect to STS or with respect to prolonged speech, both will alter the speech directly. The speech pattern, both of it will change the speech pattern itself. Even if it is prolonged speech, I'll be saying na hesaru Rakesh, or STS will be like king, climbing, like this. We'll be speaking at one beat at a time. But here the generalization is the key. What will we do? We will do within a 4-wall, but the child may not be comfortable using this technique in a natural situation. So take the child outside of your clinical situation and make him speak in a natural situation, like in a canteen. Real situation, ask him to buy something using that treatment technique, or take him to a park, or take him to a another clinician. If I'm the male clinician, take him to a female clinician. After that, with your presence, and again with your absence, and with multiple clinicians like 4 or 5, then you can speak with a security guard or with a stranger. In your presence, ask him to use the treatment technique, and if there are any difficulties faced by the child, you are there to correct it. So in your presence, start generalization outside the clinical situation and boost him, motivate him to use the therapy technique. In most of the time, what do? I use this analogy, saying that due to something happens, my leg is broken. Okay, so what do the doctors will do? They will put some plaster and they will give clutches. So in order to get healed to that 2 months of period, I should be using clutches in order to get my leg going. So think prolonged speech or STS as clutches. Okay, now is it okay for you to speak kage or kage? Which is better? The child or the subject will only say, instead of saying kage, he will say kage. So for time being, use kage or kage, that is STS or prolonged speech. After a certain period of time, when the disfluencies are vanished or it is reduced drastically, then I will remove the prolonged speech or STS. Then you will be left out with only fluent speech. So that is how we need to counsel, and that is how we need to start from one step to another. So unfortunately, what will we do? Most of the time in front of clinician, they will use these therapy techniques. But once they go to school or once they go to home with neighbors, they don't use these therapy techniques. And without this, there will be no generalization, and poor generalization will lead to poor maintenance, and this will lead to relapse of stuttering.
Another question we have is, what role do parents play for pause and talk technique?
Here, what is the role of pause and talk? Here, what I suggest is, and again, I suggest all the clinicians to make the parents part of your therapy plan, as well as they're the important team members. And when you are delivering the therapy, let them sit inside the therapy room and observe you, and ask them to deliver the therapy in front of you also. So what do? Most of the initial one, I will be giving therapy for weekly 4 sessions. Once the parent is confident, they can also go and try at home. They can also practice pause and talk at home for 45 minutes. If they are 40 minutes per, like morning 30 minutes and evening 30 minutes, they can try. But most of the time, I don't involve much of the parents, because they don't have time or they are not interested. I will teach the child itself, saying that whenever you encounter stuttering, you stop for 5 seconds. Then you restart. You count 5 like this, and then you restart. That is how I train the child itself. But you can involve parents if they are liking. They can deliver treatment morning 30 minutes or evening 30 minutes. With prolonged speech, they should make the child, because most of the time what will happen, child will forget to use prolonged speech. Even like suddenly if you ask him what is your name, he might say Rakesh, or he might say Rakesh. Because of no stuttering, he will say without prolongation. But with or without stuttering, he has to use prolongation everywhere, within the clinic, in school, everywhere, unless and until I say or I instruct to reduce prolongation, he has to do. At that moment, parents can remind him whenever whatever work they are doing, and if the child is not using prolongation, a mother can remind, what did the clinician or what did sir teach you, speak in prolonged manner. Like that, they can remind them.
One more question. Is there any specific toys or reinforcement strategies to keep the child interested in therapy?
So usually as they are school age population, if they are towards kids like toddlers, these toys will do. Most of the time a social reinforcement or verbal reinforcement will do. But if you still insist, you can go for some toys, or you can go for some reinforcement. Like example, if you achieve 97% fluency, after 10 sessions, you will be given some toy or a car or something else. But as they are school age population, I don't think toys will do. But therapy books like story books or activity cards or story cards, that will be used to elicit speech response. But toys, I don't think that much of a use. But for 6-year or 7-year-old, you can use toys.
Another question is, if a child has misarticulation and stuttering, which one should be treated first and why? Or can we do it simultaneously for both? Like divide the
This, I think
sessions?
this is the most famous question. This came in Santosh's talk as well as Divya's talk, and now also it's coming. As Santosh said, please treat both. No need to discriminate, because most of the time what will happen, stuttering will be associated with misarticulation or speech sound disorder. So treat both. Work on fluency technique as well as work on like phonetic placement technique, like anything, like work on both articulatory drills as well as stuttering treatment.
And so one more question. How do you recommend generalization in prolong and pause and talk technique? And how many sessions do you think it will take? Or, as a parent, when they ask us in private practice, like how long the treatment is going to be, or how many sessions do you think it's going to take more? So how should we answer that?
Madam, I think generalization part I answered. Once we induce fluency, then the next one is generalization. Even if it is private practice, please take the child outside in your presence. It is not like therapy is always within 4 walls. In your presence, for that 60 minutes only, take him outside, ask him to speak with that therapy technique. And if something goes wrong, you will be there to correct him, or you will be there to defend him. So he needs to go outside and talk in your presence, then in clinician absence, then at neighbors, like that. With different situation, generalization can be done. And opposite gender also, and other authorities, like he will be very comfortable to speak with friends or with parents, and ask him to speak with police or security guard or a stranger or HM in your presence or in your absence. And that could be done through phone also. Like if it's not possible to take him in person, and we can schedule a session or a time, so that his teachers or anyone who he's afraid of taking in talk over phone or Skype sessions, like that generalization can be done. And the second question was how many sessions it will take. Trust me, as I already told in the first slide, stuttering is heterogeneous in nature. Even though I have moderate stuttering, and that level of stuttering will not be same. And one of the Santosh's paper is there, it's been published, saying that the severity of stuttering varies. Day-to-day variation will be there. And even within a day, there will be variation, morning to night. So we cannot exactly tell this many sessions is required. On an average, for mild stuttering, 15 sessions. For a very severe stuttering or severe stuttering, it may take up to 40 sessions. That is weekly thrice. 40 sessions. That might come around 3 to 4 months. For very mild and very mild, it can take up to 15 sessions. On an average, is 25.
So one more question is there. Can you demonstrate on how to teach a costo-abdominal breathing to a school-going child? Like, how can we demonstrate that?
Like either we have to show them video, and the second one is tactile, that we have to place one hand on the costal muscles and the second one on the abdominal muscles, and we have to make him feel both the both the muscles that are working together. As you know, there are three types of breathing: thoracic breathing, as well as abdominal breathing, diaphragmatic breathing, and some abnormal is clavicular breathing. So we have to teach him exact pattern, and both the muscles have to be used to breathe. And trust me, I have not used in my clinical setup, and I don't have hands-on experience. Even I was doing YouTube. So in that, they show that one is tactile method and another is through demonstration, that is video. Through videos you can teach them, but I have not done in person.
Okay. I think we have answered most of the questions.
And if you have any questions or doubts, you can write to the given email ID.
Right, sir. I request every participant to, if there's any further question, you can mail either to sir or connect through us. We will get in touch with Rakesh sir for you. I would like to thank you, sir, for this thought-provoking and refined explanation of everything. And a big applause for all the delegates for being such a graceful listener. An event like this can never happen overnight. The wheel starts rolling weeks ago. It requires planning and a lot of discussions. We have been fortunate enough to be backed by a team of very proactive and dedicated professionals. That is Isha and SIG Private Practitioners Group. And a special thanks to Isha back office, Ms. Shweta, for all the technical support. To keep the learning wheel moving, I would like to remind you all for an upcoming webinar that is on 23rd September, Cognitive Behavioral Therapy in Stuttering by Dr. Pallavi Kelkar. So with this, we come to an end and wish you all a very happy weekend. And thank you, everyone.
Thank you, ma'am.
Thank you.